If Dr. Chetan&Sanjay is not with us, we'll move on to our next presenter. Can I call Chetan Tiwari from Delhi World Public School, Bhatapara to present his paper titled Structural Intersectionality and Healthcare Access, Rethinking the Default Patient in Healthcare Policy.
Yes, ma'am. Let me share my screen.
Yes, we can hear you, sir.
Okay. Good afternoon, everybody. I am Chetan&Tiwari from Delhi World Public School, Bhatapara.
I am Tiwari. We are students from Delhi World Public School, Bhatapara.
Just before starting with our presentation, I would like to ask a question. Have we ever considered whether healthcare systems are truly considered universally accessible for everybody? This is the question we are going to talk about here today with my presentation on the topic, the default patient. Okay. To answer this question, here is the roadmap of what we'll be speaking about in this presentation.
We would begin with identifying the assumption, then we will examine the barriers created because of that assumption. Instead of studying these barriers separately, we will use intersectionality. This helps us rethink healthcare system design in a collective manner. Finally, we examine the role of AI and governance as solutions.
Okay. When we hear the word patient, we often imagine that every patient is treated equally. But unfortunately, that is not the case, and systems that we have work around an assumption of a patient, which is a very typical one.
That typical patient is often assumed to be a male person with an able body, is financially stable, and living close to an urban area. If someone matches this profile, then getting good results from a healthcare system becomes much more easier and likely.
The main issue starts to arise when a person who doesn't fit this criteria, then instead of the system benefiting them and providing them with good healthcare, they are often expected to adapt to the system regardless of their issues. So, what are these barriers faced by those who don't fit this default patient? Let's look at them.
The first barrier is gender, where patients may face diagnostic delays or symptom dismissal because of their gender. The second is disability, where physical accessibility and communication barriers limit healthcare access. The third is geography and distance, where people living in rural regions often struggle with limited infrastructure, long distances to healthcare facilities.
While each of these barriers are very significant on their own, they are considered as major challenges themselves. But the research argues that in the real world, these effects overlap each patient, and the patient becomes a victim of the compounding effects of each of them combined. To understand this overlapping effect, let's understand intersectionality. The healthcare system does not interact with each one of these aspects of a person's identity. If every patient enters the system with multiple realities, such as their gender, their disability status, where they live, their geographical location, these factors do not act independently. They interact with one another, and together they influence the healthcare outcome of that patient. And the core idea behind this is intersectionality.
So instead of asking, is this patient a woman or does this patient have a disability, we should ask, how do all these factors combine to shape this patient's healthcare experience? Let's understand this through a real life example comparison. Let's compare two individuals entering the same healthcare. The first is a healthy urban man living close to a healthcare facility. The second is a rural woman with a disability.
Both individuals enter the same healthcare system in the same country, but their experiences and the healthcare outcomes are greatly different. Looking at the rural disabled woman who has to travel a great distance to get access to effective healthcare, faces many practical issues along the way which are expected, which limits her healthcare access, and this results to a poor experience and a delayed diagnosis. Whereas the physically abled urban man who has access to good healthcare facilities is able to reach the facility and with little efforts and get a super specialist faculty, which is overall makes his experience better and the early diagnosis if his illness is possible?
The difference isn't because one patient deserves better healthcare. It's because the healthcare system was designed around conditions that not everybody shares. This raises an important question. If outcome differs so much, who is actually responsible for designing this system? Let's look at it. Every healthcare system is designed by people who decide how it should be function. They decide what problems deserve attention, where hospitals should be built, how resources are distributed, and even what information is collected. These decisions may seem ordinary, but they directly influence who deserves timely healthcare and who continues to face barriers. If these decisions are made without considering different realities and the concept of intersectionality, then some inequalities continue to exist, even with new reforms.
Okay. Let me change it. Nowadays, whenever we talk about reforming or solving any large scale problem, the first solution that comes to mind is artificial intelligence. Simply use an AI model to fix any problem. But we need to understand that reforming a society's condition cannot just be relied with AI. What if AI is learning from the same healthcare system that already contains these inequalities? If the data itself is biased, then technology alone cannot remove the bias. It may simply make the existing systems more faster or transform it into something similar.
This is where governance becomes equally important. Governance simply means how healthcare systems are planned, regulated, and managed. AI can assist doctors, improve diagnostics, and expand telemedicine. But it cannot decide what is fair. These decisions still have to be made by policymakers, healthcare institutions, and society. Therefore, AI should not be viewed as a replacement for structural reforms. Instead, it should be used as a tool that supports a healthcare system that already designed to be inclusive, equitable, and intersectional, using AI as a tool and governance as a decision-making body.
In conclusion, technology alone cannot create equality in healthcare sector. Only when healthcare systems recognize this diversity of every patient rather than assuming a default patient around them to then only healthcare truly becomes inclusive and accessible for everyone. So that was all from our side. Thank you for your time.
Thank you.
Thank you so much, Sir Chetan Tiwari. Your research is very interesting, and thank you for bringing the critical issue of ableism that exists within the healthcare system all over India. And as a researcher working in disability studies myself, I have seen how relevant that is and how that stagnates and hinders healthcare policy in different parts of India. So that was a particularly interesting topic, and I would love to see a further development of your research. Next, we will call Dr. Sheetal Sanjay. Is Dr. Sheetal Sanjay with us?